Oral presentation 13, refractory gastroesophageal reflux symptoms, exploration of underlying cause. The authors are Arya Singha JVS, Rangana HMP, Anuttara HRCS. The presenting author is Pereira KDR.
Okay, good morning. I'm going to present my study on this refractory gastroesophageal reflux symptoms and exactly what do they have or exploration of underlying cause. Now, the gastroesophageal reflux disease, what is it? And it is a condition with troublesome symptoms and complications caused by reflux of stomach contents. And the definition is taken from Montreal definition classification, which was published in 2006. Here, the complications mean because they can, even though it's a benign disease, they can have stricture formation, they can do Barrett's esophagus, and they can have esophageal cancers. That's what they have mentioned complication. And it is one of the most prevalent gastrointestinal disorders worldwide, and heartburn and regurgitation are the cardinal features of GORD. But even though those are the cardinal features, they can come up with non-cardiac chest pain, epigastric pain, and pulmonary and throat symptoms like chronic cough and hepatic throat clearing and dental erosions. And it's often a chronic problem with significant impact on quality of life, as well as a very high financial burden because of cost of drugs, long-term drugs. Now it's often a clinical diagnosis, and acid suppressor medication is the first-line treatment. Yeah, we have a wide range of treatment, including PPI and H2 blockers, but PPI are the cornerstone of treatment. But unfortunately, from our clinical practice, from our clinical experience, we know that significant proportion of patients with reflux symptoms, they actually don't respond. They keep on coming to you again and again. And that's why we call them refractory GORD, and in better terms, refractory reflux symptoms. And that's what I'm going to say. That's the correct term that we should use, and it will be evident from my study findings. And the objective was to identify the cause of PPI refractory reflux symptoms, including the prevalence of true GORD. So I carried out a descriptive study at Columbus South Teaching Hospital, which is one of the leading tertiary care hospitals in our country, from October 2019 to June 2020. And the patients are referred from both inpatient as well as an outpatient setting. And the ethics approval was taken from Columbus South Teaching Hospital Ethics Review Committee. Now, we took all patients with refractory reflux symptoms. That means they should have either heartburn or regurgitation, and despite appropriate PPI therapy for at least 8 weeks. Now, appropriate means they should take about half an hour before meals, and the compliance should be okay, and they should take the appropriate dose, that is about dose and twice daily. So that was very important. And the patient less than 18 years and who were having other complaints like dysphagia rather than reflux symptoms, and the patients who has undergone prior investigation, including endoscopy, manometry, and pH studies, and who has undergone therapeutic procedures like surgery or endoscopic procedures, we actually excluded them from our study. And this is exactly what we have done. Now, starting from the patient with refractory symptoms, we took them and we offered them the endoscopy, and we made sure that the patient with significant abnormality other than hypertonia, esophagitis, or other evidence of GORD, like peptic stricture, Barrett's esophagus. I mean, if the patient was found to have a carcinoma or severe peptic ulcer disease, we actually excluded those patients. And we offer esophageal biopsy in patients if we have a doubt in eosinophilic esophagitis based on the clinical parameters. And on endoscopy, if we found reflux esophagitis, LAC or LAD, or peptic stricture or Barrett's esophagus, those are taken as definitive evidence of GORD. So they were classified as, that was the correct term, the PPI refractory GURD, because they were having definitive evidence of GURD on the endoscopy. Now, if the patient didn't have any evidence of GURD in the endoscopy, we offered them high resolution manometry and 24-hour pH impedance monitoring. And that was done after stopping PPI therapy for 1 week. And these were the findings. So, a study included 22 patients, and the mean age was 40 years. And the 14 patients were males and 8 were females. And definitive evidence of GURD was found in 4 patients. Out of 22, 4 patients were having GURD in endoscopy. And esophageal biopsies, we actually took from 5 patients, but unfortunately, but there was no evidence of eosinophilic esophagitis on all those 5 patients. And high-resolution manometry, which was carried down using a MMS water focus system, and revealed minor disorder of peristalsis in 3 patients. Actually, those are unlikely to cause symptoms in patients, the minor disorders. And interestingly, acid exposure time was more than 6%, was found only in 2 patients. And the 4 patients were found to have borderline acid exposure time, that is 4 to 6%, but significantly high reflux burden. So taking these 4 patients and these 6 patients and the 4 patients who were having definitive evidence of GURD in endoscopy, finally a GURD was diagnosed in 10 patients. And the majority, that is 12 patients, more than 50% were diagnosed have a functional disease, either functional heartburn or reflux hypersensitivity. So in conclusion, a functional disease is evident in most patients with refractory reflux symptoms. And that's why as I spoke earlier, it is very important to term them refractory reflux symptom rather than refractory GURD, because they are having a functional disease. And this highlights the need for appropriate investigations to avoid unnecessary treatment. Because if these patients are going to somebody, they might offer them surgery, endoscopic therapy, and in fact, they are not going to be effective. Another thing, we have to make sure the patient are not given PPI unnecessary. Some people are on long-term PPI, years and years, with very high cost and with quite a lot of side effects like interstitial nephritis and osteoporosis. Those things can happen. So limitations, the controversies related to the definition of refractory GURD, because fortunately in last July, actually we came up with a guideline, and where they say that symptoms has to be there for at least, the patient has to be on treatment for at least 3 months before you're calling them refractory GURD. But at the time of my study, there was no such definition. And so I actually went up with the most the evidence-based definition at that time, which was about 2 months. And there was a bias in sampling technique, because I took patient from our clinic, and which is a highly selected patient population, because as we know that patients who are having more severe symptoms, they tend to seek attention. And most of the time, patients GURD, they are managed in a community setting with a general practitioner. So my findings might not be generalizable to the general population. An inadequate sample size, that is in fact because of the high cost involved in these procedures, but I'm planning to actually expand my study size. Another thing, limiting the esophageal biopsies to those with clinical suspicion. And in fact, actually now current guidelines recommending taking biopsy from each and every patient. But studies done in our country, and we have found that the eosinophilic esophagitis is not a very common disease. And therefore, offering biopsies for each and every patient is not going to be helpful in our city. So I think more and more studies are needed in terms of the true prevalence of eosinophilic esophagitis rather than going for biopsies. Thank you. Any questions?
Yes, we can go for questions now, madam.
When you say functional, what this really means that? Is it some functional disorder? Is it a functional disease in the motility? Or?
We don't actually, madam, we don't know exactly what the functional disease is actually, because from the investigation that we have, we can't find a abnormality. We are going to call them functional. But in future, actually, this classification, we might find even abnormalities that they are cut, and we might actually call them organ. So actually, the things I call at the moment, if we don't find objective evidence of acid reflux, we are going to call them functional. So it's actually a thing that's going to change in future.
I think it's a good study. Only my main concern is, particularly in a study that is looking at the prevalence, sample size is a very important parameter. So your sample size is small. So what is the ideal sample size for the sample size calculation? And because then we can get an idea of whether how reliable the results will be. And then the other one is how comfortable are your results compared to the similar studies done in other sectors.
I accept, madam, the sample size is not inadequate because if you calculate the sample size here, it will come as more than 200. But the PhD studies in India are very expensive, and you have to get the patient admitted to the hospital. So therefore, I think this is going to be an eye-opening study, madam, where we can actually focus our more bigger sample size, bigger studies, which I'm actually working on that at the moment. And the findings, madam, I know that there are studies published in other countries, but at the moment we don't have any data from our country. This is the first study, and because symptom perception depends on the population's culture and tradition. That's why I thought our population data are very important for the clinical management.
Definitely. So, do our data from this, even the small sample, does it correlate with the figures given in other countries, or does it differ?
It differs, madam, because in other countries, about if you take the refractive GORD, about 40% they will have functional disease. But in my study, actually, majority, more than 50%, they were having functional disease. That might be because my sampling method, that would have been a problem, madam.
Thank you, sir.